Good evening. On behalf of the Student Academy of Doctors of Audiology, I would like to welcome you to today's Student Practice Management webinar, Billing and Coding. My name is Andrew Abernathy, and I am pleased to serve as today's course coordinator. I have just a few housekeeping reminders before we begin. If you have any technical challenges during the session, please use the chat feature to make me aware, and I will be glad to assist you. Please type your questions into the question queue, and they will be addressed by the presenter at the end of the presentation. Today's presentation is being recorded and will be available for online viewing next week. At this time, it is my pleasure to introduce the course moderator for the session, Kayla Dubb, SATA Board Vice President and fourth year AUD student at the University of Florida.
Thank you, Andrew. On behalf of the SATA Board, I am excited for the opportunity to welcome AUD students from programs across the country to this session, Billing and Coding. It is also my distinct pleasure to introduce today's course leader, Dr. Abel. Dr. Abel, AUD, is the Manager of Coding and Contracting Services for Auditory after serving as staff at the American Academy of Audiology and is the President of the Academy of Doctors of Audiology. She also has her own private practice in Alliance, Ohio. Dr. Abel is the editor of the Essential Guide to Coding and Audiology, Coding, Billing, and Practice Management, the author of a chapter in the Essential Guide to Coding in Otolaryngology, Coding, Billing, and Private Practice Management, the 3 editions of Strategic Private Practice Management, a patient-centered approach, business and procedural considerations, and has authored articles in various audiology publications. Until recently, she was an adjunct assistant professor at A.T. Still University.
So I guess we'll go ahead and get started. Kayla, thank you. Andrew, thank you as well. So we'll go ahead and get started, and I will leave enough time for questions at the end. I just want to also tell you, number one, I'm so happy to be here with you tonight. At my age, I'm happy to be anywhere. But at any rate, I'm very happy to be here with you tonight, and also very happy to have the role as president of the Academy of Doctors of Audiology. So with that, I wanted just to have one little housekeeping item, and just to let you know, there are a lot of slides in this presentation. Many of them will be for reference only for you for tonight, for the next few months, and hopefully for some of your professional life as you go forward and work clinically. I'm sure there will be some changes to some of these codes and things like that, but for what we have now, it's just been kind of created as a resource for you, especially as you go forward in the future. So with that, we'll go ahead and get started. I don't know that my slides want to advance. There they go. Okay. I always like to know what I'm in for when I'm sitting where you are. So we'll talk about the 3 different coding systems, and I know you all have varying exposures to these. So if this is a little basic, my apologies, but I don't know what you know. And so I want to make sure that you have a really good background as best as we can. When we talk about the CPT codes, which are the procedure codes, 92557 pops into my mind, which is pure tone, air, bone, and speech. The HCPCS codes are what CPT does not address, and those are the hearing aid codes, and those are the ones that generally begin with a V in terms of the hearing aid side, or L for those osseointegrated devices, or for cochlear implants. And then the diagnosis codes or disease codes are the ICD-10 CM. CM is used mostly in physician offices as well as private practice audiology offices. For those of you in a hospital setting, you use ICD-10 PCS, and it's a very different coding system. But for tonight and going forward, for most of you, this will be the coding system with CM that you will be using. And also we'll go through very quickly billing and what the claim form looks like, because I think when you can see it, and now with electronic billing, seeing what the claim form looks like is kind of not very common. So I think it's helpful when you can see what goes where so that you know what's important to think about as you do your testing and do your reports and things like that. So with that, we'll get into the meat of things. I love humor, so let's start with a little, and that concludes the verbal portion of our playground equipment presentation. Now let's begin the slideshow. So a few things when we code, things we need to think about. The first of which is, the first of which are all three coding systems need to support each other. You may have only 2 codes on a claim form for that date of service, and that's fine. You may have a couple CPT codes, but you have to have at least 1 ICD code. If you're billing the hearing aid codes, the HCPCS codes, you may also be billing the CPTs at the same time. And also that you can have just 1 minimum of an ICD-10 for each claim. So it's 1 in 1, or it could be 2 in 1. Or you can have a multiple, there's plenty of room, as you'll see on the claim form, so that you have many options. And we'll talk about that because I think it adds value to you as a practicing audiologist. So if you ordered them hard copy, this is what they would look like for this year. So again, the ICD-10 CMs you see there are for offices. So I think that's helpful if you, many of the professional organizations have their own copies. Many practices do, or they should. Sometimes they don't change very much from year to year, but many times they do. And also this is where you can purchase them, so you can have them in your reference library. If you purchase all 3, it's usually to the tune of, and hold on to your seats, they're not inexpensive. If you buy it, you can buy a package for probably less than $300 to $400, which is, I know, a lot of money, but it's part of the cost of doing business, and you have to know how to code properly, or else you're not going to get paid. And you also need to code properly in order to keep things on the up and up. When you sit in front of your audiometer and you're kind of creating or whatever piece of equipment you're sitting in front of to provide the testing that you do, you're building a case for what you're trying to discover from that patient, what they've told you, between their case history to doing otoscopy to starting to begin your testing process. You are building a case for whatever the diagnosis will be. And Dr. Cavett will be talking to you next week, not only about Medicare, but also medical necessity. And that is critical for all payers. You have to prove what medical necessity is, which generally, a very simple explanation, is a change in hearing balance and or tinnitus. That needs to go in your documentation. That's part of what you'll be doing when you look at coding and billing. What you do provides value in the healthcare system. Even though you might be working alone, when you look at where your claims go and who's looking at those claims and how they're tallying up numbers, especially if it's Medicare. Medicare has an incredible data system of collecting testing and who's doing them and all that type of thing, what professionals doing that. So that adds value to the profession. It also will likely add value to your own pocketbook, especially if you're in a facility that pays you based on relative value units or productivity, and not necessarily a straight salary. And that's generally more common in larger major medical centers. Fiscal, and that's what I mean by fiscal recognition for your services. And if you're in a private practice, you have to generate revenue in order to be viable and provide services in the future. The information in this webinar on CPT codes, which again are the diagnosis or the procedure codes, is for audiologists only. Hearing instrument specialists can test for the sole purpose of fitting a hearing aid per every licensure board in the state of every state in the country. So we are the diagnosticians, and they are limited to just testing for fitting hearing aids. You need to be aware of wherever you wind up to practice, you have to know what your state licensure laws are. And especially when you're looking at hearing aid dispensing. And we have just done a good search at Auditory to look at what each state requires for audiologists, for hearing instrument specialists, and it's all over the board. So you need to know what that is, whether your state requires otoscopy, believe it or not, whether your state requires a sound treated room, whether your state requires you to do UCLs and MCLs, and also verification post-fitting. So state licensure laws determine what your scope of practice is, and that's what you have to work under. And it varies from state to state. So let's get into the actual codes. So the CPT codes must be ones that are typically performed by audiologists. If you bill a code that's not, it may trigger things you don't want it to trigger, like an audit. And also the codes must be supported by the diagnosis that you fix to that claim. To the insurance company, if that's who the payer is, could be private pay, could be a variety of payers. It must be apparent to them why you did the test that you did. And don't be surprised if they ask for chart notes. The hearing aid claims will predominantly be the V codes that I mentioned earlier, the HCPCS codes. So I'm going to go through some of this very quickly because, like I said, there's a lot of slides here that are mostly for your resource and reference. So you'll list on the claim form the CPT code, the ICD-10s, and the HCPCS codes, and again, they have to be all tied together and make sense. This is what the claim form looks like. So you see a dark red line about halfway down the form, right in the middle of that first arrow that goes head south. So everything on that dark red line going above that indicates that's the patient information. Everything below that is the information that you're going to import into that. This is generally done electronically. This is generally done by a clearinghouse. It is rare that you have to do this manually anymore. So I just want you to see what goes where so you can kind of have it in your mind graphically, because I think it makes a lot of sense. So you can see where the number, or where the oval is, the long number. If you look, it goes from A to L. That's where the ICD-10 codes go. So you could conceivably have 12 diagnoses in there if that's what is applicable. When we start talking about like the ototoxicity codes, you'll probably have a minimum of 2, maybe even 3 codes to describe the testing you did for a patient that you're seeing for ototoxicity. For a patient who comes in for a fairly basic hearing evaluation, you may have 1 ICD code and maybe 1 or 2 CPT codes, which go in the smaller circle at the bottom. All the other information is the date of service, if you need a modifier, and we'll talk about those, as well as at the far right, in box 24J, your NPI number goes there. So that's how they know you're the provider who did that service. So I just kind of, again, wanted you to sort of see what that looks like. The coding mantra, I'm not a certified coder, nor do I play one on TV, but you always code for the reason for the test. And Medicare has that written in a transmittal. The reason for the test, again, why is that patient there? And you have to make this medically necessary, and this is what the crux of that is. The first sentence in your documentation should be patient, or something to this effect. Patient presents with tinnitus right ear or hearing loss left ear or whatever it is. That should be right there in your first sentence as to why are they there to see you. You can also code with signs and symptoms, which could be the same thing. Also, their complaints also can be the same thing. Do they have tinnitus? Are they having balance issues? Do they have hearing loss in one or both ears? Or no hearing loss at all in the other two symptoms? So those are things that you need to include. You can also include the outcome of and this should be in your report as well, the outcome of what you found. Was it sensory neural hearing loss? Was it tinnitus? Can you match it? And there's a code for that. Is a conductive hearing loss, which you would verify with an ear bone gap and tympanometry, for example. So what is really important and critical is you code for what you did and what it indicates. You don't code by how much you're going to get paid. That'll get you in trouble. And I don't want to ever read about any of you in the paper or see that your name comes across when I get an OIG in the Office of the Inspector General who looks at Medicare and Medicaid fraud. I don't want to ever see any names there that could be familiar. And I say that sort of jokingly, of course. So you need to code by what you did, what you found, and not by what you're going to get paid. So let's dive into the CPT codes. The most common one in our core code is 92557. Until January of 2010, it was the only bundled code that we had. And if you're thinking bundled versus unbundled, that applies to hearing aids more. And the preferred term for that is itemized. But with CPT codes, it is illegal to unbundle a bundled code. So that's why I'd like to have the terminology as clear as what I just said. So when you cannot unbundle a bundled CPT code, that's illegal. So we don't want anybody doing that either. So in 2010, we had, because of how Medicare looks at the data and figures out ways to save money and reduce the reimbursement, we found that to be very true with the vestibular codes. So at that point, you could do the 4 codes you see there next to the big word vestibular. Those were all separate, and they still are. But if you do all 4 of those, they're now lumped together in 92540. Tympanometry was by itself is 92567, and thresholds was also by itself is 92568. They lumped those together too. And then because they looked again at dates of service and saw that all these things were done on the same date of service, and you can save a ton of money if you're the payer by combining them. And then they did away with and deleted what was a acoustic reflex decay code, because you can't do that without doing acoustic reflex threshold. So now that is 92570. This year we had some interesting code changes. 92626 was not really used properly. It is to evaluate post-operatively or pre-operatively candidacy for a patient who's considering cochlear implants or any kind of implantable device, BAHAs, Pontos, auditory brainstem implants, anything like that, and of course cochlear implants as well. It's a time-based code. We don't have very many of those. And on those codes, I'm going to strongly suggest that you write down in your documentation what time you began to perform the service and what time you ended. If there's ever an audit where sometimes payers are required to do audits, where they come in and look at your chart notes and request those from you, then you have that covered to demonstrate you did an hour. If you go over that hour, then you can bill for every 15-minute increment after that. If you did 92626 and it did not take you an hour, you don't bill for it, because you cannot use modifiers to indicate a reduced service on these time-based codes. Another new code, so that code was around, it's just been reworded and more descriptive, so it won't be misused like it probably was up until this point. 92548 used to be computerized dynamic posturography, and now it's got 6 conditions, and it tells you right there, I won't read those to you, what those are, and everything includes, it's interesting because all our newer codes have including interpretation and report, you should be doing that anyway. You indicate in the record, don't assume somebody that you're sending a report to knows what you did and what it indicates if you send a copy of the audiogram and only that. That's not good patient care. You need to interpret what that means. You don't need to be very explicit. Physicians probably want it very quick and easy because they don't necessarily have the time to read it. And then they can read the regular report if you so choose. It's helpful to do that, or bold what you critically want them to know, and then they can read the rest later if they so choose. But anyway, interpretation and report is something you always do, and that's part of the code. Then we have a new code that adds in MCT and adaptation, the ADT, with posturography. So that's a brand new code this year. So I just want you to be aware of that too, if any of you are doing any vestibular sites. And if so, you're going to get a really full view of audiology. These codes, I'm not going to go into any detail. They don't say with recording after each item, so Medicare won't cover them. They will cover the rest of what I'm going to talk to you about. So for those of you maybe who have seen a VNG or an ENG, you know you can do calorics. This used to be billed differently too. So now it's either monaural, both ears have the same temperature, or you get one warm, one cold on both sides. We already talked a little bit about 92540, which is a basic vestibular evaluation. That's 4 codes, 4 tests. If you don't do all 4 of those and you just do 2, for example, then you use a modifier, and we're going to talk about that in a little bit. Then again, and these are just the rest of the vestibular tests. I'm not going to go through each one because of time, but I want to highlight the Rotary Chair, 92546. This has been an interesting code, and because of misuse, and that by misuse in this case, I mean physicians who don't have a Rotary Chair or other professionals who do not have a Rotary Chair. And I don't know if you've ever seen one, but they're large. They take up a lot of space, and they also are highly an expensive piece of equipment. You could probably buy a car for what Rotary Chairs cost. So it needs to be a true billing of using that chair if you bill 92546. And the Medicare found out that a lot of places were billing for a Rotary Chair and didn't have one. So oftentimes now, to avoid fraud, they request that you put the serial number of the chair on the claim form. So that's not an uncommon thing in case you're working at a facility that mentions that to you. So you'll be prepared for that. And then we have the electrodes. I already mentioned to you about these 2 codes. I just put them in there so you would have all the vestibular codes together. We talked about some of these, and I want to highlight screening to you, because screening and threshold, even though they're just 1 digit differently, they're very different in terms of what they look at. So screening air only means it's pass or fail. You present maybe at 25 dB 4 frequencies. They either pass or they fail. You can't fit a hearing aid in any state based on a screening. It doesn't tell you anything other than somebody probably has some hearing loss. You would have to do a diagnostic in order to find that out. So air only is threshold. That means you have discrete points on an audiogram for where the patient responds. You don't have that with a screening. So I just kind of wanted to caution you about that. And the rest, I'm sure, are pretty self-evident for you. The core code, as I mentioned, 92557, is pure tone airborne SRTs and word recognition. OAEs have a screening, and they also have more in-depth codes that are in the next couple of slides. 92555 is a screening for OAEs. You, again, either pass or fail. Anyone can do that, doesn't have to be an audiologist. and it's often done in a hospital as part of a delivery of a baby before they are discharged. Some of these other codes are so old, probably only a handful of people in the country are still doing them. I think these are all pretty self-evident, so I'm going to go past those. I'm going to talk about the difference between 92579 and 92582. Visual reinforcement audiometry includes speech or tonal information. So if you're using VRA to try and ascertain what let's say a baby, where their thresholds could be, then it has to include tone information or speech information, them looking and responding to whatever the visual reinforcement is. For conditioned play, this is a really old code. 92579 was readjusted a couple of years ago. So it's different. 92582 has been around for a long time, and it has no mention of anything like VRA does. So if you're using, block in a box with a child, you can bill for the test and you can bill for 92582, and you certainly want that in your documentation. 92583 is another test you could use for pediatric opportunities. And then there's the two evoke potential codes. Limited generally means screening. Comprehensive would be if you're trying to ascertain a threshold or a site of lesion, just so you know the differences there. These are the two OAE codes, 92587 and 88. These were recently, in the last 5 years, 10 years or so, rewritten, and with 92587, you have to do 3, and all our codes, all the CPT codes are bilateral. That means you do have to do everything, like if you did 3 to 6 frequencies, that's in both ears. So it would be a total of 6 to 12 frequencies. So that's, you can do that with distortion products, or you can do transient evoked potentials with that too, otoacoustic emissions rather. Again, interpretation and report is required, but it is with everything. It's just listed here separately. And then the more in-depth OAE code 92588 is used for a lot of reasons: ototoxicity, malingering maybe, tinnitus, a lot of reasons. You're trying to get more cochlear information. Again, you have to do the interpretation and report. And with 92588, you are doing a minimum of 12 frequencies in each ear. So that would be a total of 24. And these are some of the hearing aid codes that are on the CPT side. So if you're doing a hearing aid check, you have options of using CPT 92592 or 93, depends on the payer as well as what you're doing. I'm going to highlight the cochlear implant codes for you. So these both, they are age restricted, and they are also descriptive of what they're doing. So if you see 92601, it's for a child under 7 or is 7 who is coming in for their initial stimulation of their cochlear implant. If they're returning for mapping or to have things adjusted as they get used to being exposed to the cochlear implant, and they're still 7 or under, and they're coming in for mapping, then you use 92602. On the 92603, that would be for anybody 7 or older. That's also 603 is like 601. It's the initial tune-up, the initial stimulation and activation of a cochlear implant, whereas 602 and 604 are the mapping or reprogramming as they get used to their devices. Evaluation of central auditory function, for those of you who want to do central auditory testing, processing testing, these are also time-based codes. And again, you'd want to use your start and end times in your documentation. And you'd want to add and figure out if you have to go over the 1 hour of 60 minutes, also known as, then you would need to know how many units you would need for each 15 minutes. We have one dedicated tinnitus code, and that is 92625. That's assessment of tinnitus. So you're trying to match it by using bracketing methods of trying to figure out what frequency, if it is a frequency, what the pitch is and how loud it is to the patient. And then you would note that in the documentation, as well as if they have any response to minimum masking levels. This is a great code for us to have. And again, we talked about 626 and 7 as far as using for pre and post-op evaluation of somebody who's looking at a implantable device. And then auditory rehab is something audiologists certainly can do by scope of practice. Medicare at this point does not recognize us for that because it's treatment, but we can do it. And if you choose to do it and it is a Medicare beneficiary, it's private pay. And it may be that way with other payers as well. And the code you choose is dependent on when the patient lost their hearing. Was it prelingually or postlingually? Finally, the last of the CPT codes, there is one code for auditory brainstem implant, and it's per hour. I understand it takes 4 hours on the average to start to stimulate that. So you would bill for every hour, and that would be by units. And that unit column is right next to the CPT column on the billing form that I showed you earlier. 92700 is sort of a wastebasket, so to speak, code. Whenever there's not a dedicated CPT code, and there's examples of when you would use it, like for the quicksand, for example, there's no dedicated code for that, but you could use 92700. You might want to have a narrative all set to go, because a lot of times 92700 is denied, but again, you may include your documentation, include in the report why you did, what you learned from it, and how it impacted that patient and their diagnosis. I can tell you there will be VEMP codes starting in January, but that's about all I can tell you at this point. I don't have numbers, and they won't be available until the CPT codes are published, and that's in November. So there will be several VEMP codes, so look forward to that if you're in a facility where VEMPs are being performed. Here are the codes just kind of grouped by their number, just so you have that handy, so you don't have to scrounge around too much. The AMA, I want to mention this to you, the AMA owns the CPT codes. You have to, it's their intellectual property, and if you want to use that information, you have to pay them for it. So, and it's not inexpensive. So if you go to try and find a code descriptor on the internet for CPT codes, you won't find it. The professional organizations have access to that information, and we do as well at Auditory. So if you need the information of what you have to do in terms of a new code, the professional organizations, ADA, ASHA, and AAA generally come out with something together when codes are changed, so that we offer the same information to all of our members. So again, we will be seeing some new codes next year, and not just VEMPs. So there is also an AMA publication called the CPT Assistant, where questions can be posed, and that's been done for audiology specific codes in the last 10 years, more so in the last 10 than before. So I've mentioned modifiers, and that's when you're doing something that's a little bit different than what the average typical patient code and services that you're providing. For example, the quickest and easiest one is, all our codes are bilateral, but maybe you only need to test one ear, or maybe the patient only has one ear. So therefore you would use a 52 modifier, which is reduced services, and that goes right on the claim form, right next to the CPT codes. You have to do this as part of what you do if one of these applies. So I'm going to go through the modifiers now. So the 22, and these are the numeric ones, and then there's some alphabetic ones for Medicare. Then as far as the numeric ones go, the 22 is when you're doing something that takes more time, more skill than it normally would. The two examples that pop into my head would be if you're seeing a child and you have to keep telling them the directions over and over to bring them back to task. Same thing can be said for a patient with dementia. You have to keep reminding them of what they need to do. So if you're doing something like that, you need to put that in your documentation. You can go ahead and bill it and put it on the claim form. In this case, it would be the 22. And again, it depends on what your payer that you have with your insurance company. And if you join me on the 26th, we'll talk a little bit more about that too in terms of insurance. So you may get a little bit more money for using that, or you may not. It just depends on the payer. So some of our codes, and you see them all there for ENG, ABR, and OAE, have something called a TCPC split. So these codes have a portion that's a technical component and a portion that's a professional component. The professional component is that you're doing the interpretation and the report. That indicates somebody else, probably a technician, did the actual test. And if they did the test, that's all they're allowed to do. They're not allowed to tell the patient anything. You'll see this very commonly in an ENT office, maybe a neurology office, where they'll have a technician there just to do the test. The physician has to be there, especially for Medicare. The physician has to be there in the office and available. That gets billed via the physician's information. But maybe if you're the audiologist in that office or they refer the report over to you, you can bill for interpreting and writing up the report. The reimbursement's the same, whether you did all of it yourself from the testing onto the interpretation and report versus having it split up. So this only applies to these codes that you see here and only these codes that you see here. So I just want to be pretty clear about that. So if the technician did the test, they would bill, let's just say they did the comprehensive ABR, they would bill it as 92585 with the TC. And if you did the interpretation and report, you would bill it with 9258526. So I'm going to skip that. This one's fairly new in the scheme of things for audiology, and this only applies for newborn hearing screening. The patient or caregiver their family rather, the patient's too little to pay for anything, but their family or caregiver or whoever's their guardian would get this included in a newborn hearing screening as part of their delivery. So you use the 33 preventative service if you're in that kind of setting. There is the 50 modifier for a bilateral procedure. It's so questionable, and that's why I have two question marks on bilateral cochlear implants. If they are done on the same date of service, the 50 allows reporting of a bilateral procedure at the same session. So if they received and were implanted with both of their devices at the same time, this is one option for you. It's going to be payer specific. And many payers will not recognize the 50 modifier for bilateral cochlear implants, believe it or not, but there's other options. I mentioned already the 52, and that would be if you're maybe testing one ear. Another example is, you're supposed to do is if you're using 92557, you're supposed to bill for pure tone air, bone, SRTs, and word recognition. If you don't do one of those tests because all of them are required, then you would use the 52 to indicate that you didn't do all of them. And you may also need to add in there in box 19 is in the claim form as to why you utilize that. You don't have to, it's just sometimes helpful. But the most common time we would use the 52 is for monaural examples. The 53 is a surgical modifier, but I want you to be aware of it. It means you terminated the procedure because the patient was ill or having other medical issues. Probably the most common time would be if you have an ototoxicity patient, maybe it's not one of their better days to come in for a test and they just become ill, or you're doing a VNG and the patient decides to lose their lunch, then you decide to terminate it because they're ill, then you could use the 53 modifier and you're going to get a reduction in what your payment is. Finally, the last numeric modifier is the 59. So I mentioned to you a little bit ago that 92540 is the bundled code for the 4 ENG, VNG tests. So they're all there. The separate codes are all there for you. So I understand I've not been done very much vestibular work myself, but my understanding is if you want to diagnose BPPV, benign paroxysmal positional vertigo, you can do most commonly 92541 and 42. Because those codes are part of a bundled code, you would need to use the 59 modifier on 92542. So again, you may want to indicate as to why you only performed the 2 of the codes as part of that. The 76 is so rare for us to use, but it's a procedure that was performed more than one time on the same date of service. So it's different than what you saw with the 50. The 50 was performed in the same session. This is the same date of service. So an example would be maybe a patient is being seen in the morning because they were just put on an aminoglycoside, which is ototoxic. So you want to get a baseline and you only have a narrow time frame to do that. So maybe you see them in the morning, they've been given the aminoglycoside, you want to see before you go home, if you're in a hospital setting and they are too, you want to see if there's been any change. So maybe you repeat part of the testing. You would use the 76 modifier to indicate that it was done on the same day. You're not double billing, so it hopefully alleviates a lot of headaches. Those are the numeric ones. The alphabetic ones are not very many. So Medicare has 4 modifiers that you can use to indicate certain things to them, and that then indicates to them how they have to manage the claim. So the 2 top ones are the most common. GY means it's not statutorily excluded and doesn't meet definition of a Medicare benefit. A hearing aid is a classic example. And when I say Medicare, I mean Part B, which is traditional Medicare. They have no coverage for anything hearing aid related, not the testing, not the device, nothing, at least at this point in time. And that's for Part B. Part C are the Advantage plans. And those are the ones that often contract with another provider, a third-party administrator, if you will. And we'll talk about that more again in a couple weeks. And they will provide hearing aids for the beneficiary. And that's because they have a different arrangement. But for traditional Medicare Part B, they don't cover anything for hearing aids. The silly part is that many commercial payers require a denial from Medicare to pay for hearing aids, even though they know that's true. But it often just bogs down the paperwork and time. I have to grab a drink, excuse me. Anyhow, so you want to tell Medicare, I need a denial for the secondary, the commercial insurance to pay. So you just put a GY on there, and the easiest way to remember that is, gee, why do I have to do this when the insurance company already knows you're not going to pay for it? Excuse me. GA means you're expecting a denial, possibly because you're not sure you've met medical necessity. So maybe the patient saw another audiologist 2 weeks ago who's down the street, and that visit was likely covered. And now maybe they come to see you, they've noticed more change, you have a physician order, they're noting more of a change, you go ahead, you're not sure if it's going to be covered or not. And if you don't have them sign an ABN, which is the advanced beneficiary notice, that lets them know that it may not be covered and they agree to that, then if it's denied, you cannot bill the patient for that. So this is always a good thing to do. And that's the only time that you use the ABN. And Dr. Cavett will talk to you about that next week, so I don't want to get into too much detail. The other two, GX and GY, are very similar. You can use them both together. And GZ would likely never be used by an audiologist, but I want you, except maybe in an emergency kind of situation. And the only kind of emergency we have is to see somebody with a sudden hearing loss. So it's pretty unlikely you'll never use a GZ. I am going to skip about evaluation and management codes, and you may have heard about them. Medicare will not recognize us to bill for those, and these are for extra time. We only get billed or get paid by Medicare for the actual test. Oftentimes, it takes a lot longer to do a case history, and I'll give you an example. When I have my own practice, I had a tinnitus practice as part of that. And it's not uncommon to spend an hour with the patient getting their case history before you even see them and start with the testing. They're sitting there in front of you, of course. You're taking the case history. Takes an hour to do that, and you're still not even starting the test. So it may be used for that. So I'm going to tell you, if you even think about it, to read the two parts at the bottom. So that's why there's a big yellow caution sign there. It would only be for patients who take more time than what's the average, and that would be for tinnitus patients, maybe vestibular patients. And then there's other things, again, that are time-based. So I'm not going to go into any other detail about that. Cerumen management is part of the practice of audiology, but again, remember what I said at the very beginning, check with your state licensure laws, because they determine what your scope of practice is, and if it forbids you from doing cerumen management or forbids you from going beyond the first bend or whatever the caveat is, you need to abide by that. So that's what I mean by removal restrictions may apply. These are the two codes that you can use for cerumen management if you're able to bill, and that would be mostly for an independent private practice audiologist. Because there are different rules for physicians for using, especially for Medicare, because we can't bill these to Medicare, but the patient can pay, whereas a physician and some other providers can bill for Medicare for cerumen removal. So if you do it bilaterally, you'd use the 50 modifier, but it's likely it's going to get denied by doing that. Even for the physicians, it gets denied for bilateral. So anyway, I got to pick up the time here a little bit because we've got 2 more coding systems to go. So I'm going to skip some of these. So now let's move on to the ICD-10 CMs. And again, remember, you code for the reason for the test, and your documentation needs to reflect that. And because there are 12 lines on the claim form, I want you to think about the comorbidities. It's not just about hearing loss or balance. You know, if the patient has diabetes and they're prone to falls as a result, you know, oftentimes people with diabetes have neuropathy. They don't know and don't have the sensitivity in their feet. You don't have the sensitivity in your feet, you're going to be prone to falls. That is something that, as long as it's in your documentation, you can put on the claim form, but don't diagnose diabetes yourself. You'll probably have to call the physician who is their caretaker in terms of medical things. Falls risk is very important, and also especially with tinnitus and vestibular patients, they often have depression. And again, if they're under the care of a psychologist, you can certainly use that, not as a primary code, but as maybe a third code if you so choose. So interestingly, all the hearing loss codes begin with H. It's not for hearing, it just happened that way. So bilateral sensory neural hearing loss is H90.3. And I know a lot of audiologists routinely use that for just about every patient they see. And that's a little faulty because it's not always going to be the case. It's not always bilateral, and it's not always sensory neural hearing loss. So again, here's where they go in the claim form. And these are other areas to think about. So, you know, H is for hearing, the hearing loss codes, but these are some other places I want you to consider. So when you look at T, injury, poisoning, and other consequences, that's where the codes are that you would use for a patient who you're seeing for ototoxicity. So if they're coming in because they were being given a really high-powered antibiotic and it's causing hearing loss, that's a secondary code. The first one would be ototoxic hearing loss. If they're coming in because they've been given an anti-neoplastic for some type of cancer, same thing. So I'm going to go through these very quickly. But there's the bilateral conductive hearing loss code, and generally you don't want a code that ends in a 0 or a 9 because it's not specific enough. But that isn't true in this case because there's no other choice. H90.0 is bilateral conductive hearing loss, and there's no other choice for that. If a code ends in 1, like you see there with the second code listed, that means something is applying to the right side or the right ear. If it ends in a 2, that's a left ear. And if it ends in a 3, that's usually bilateral. So that's why H90.3 is bilateral sensory neural hearing loss. You see there and on the slide prior, unrestricted hearing on the opposite side. If you would translate that, that means you've got normal or near normal hearing in one ear and hearing loss in the other. So those are the codes for those instances. There's a lot of the codes, there's like 68,000 ICD codes, but it's because many of them are indicating, is it right ear, is it left ear, is it both? And then here you can see the example for the ototoxicity code. H91.3 is bilateral ototoxic hearing loss. The second code is the one that's in the poisoning family. Even though it's an antibiotic, it's lumped into that category. And that's the code you would use for adverse effects of an aminoglycoside, which would be given to somebody with a very, very a huge infection. And then there's other codes to select too. You want to avoid something that has NOS or NEC, and that's indicated in the claim form. A lot of times when you guys go out into the field and you're working and you have to use your electronic healthcare records, oftentimes these codes aren't even there because they're on a drop-down menu. So, or you can just type them in, whatever the case is. So here they are just sort of lumped together by category. You do not want to use the codes that you see listed there because they're not specific enough, nor here, but this is just a way to kind of give you an idea of where you should look. And I'm going to show you at the end of the ICD section some important things to think about that are great apps that you can have with you. So these are all the vertiginous codes. This is a system that's late in coming and being adopted in the US. Other countries have been using this system, the ICD-10s, for years. So you'll see things that are not politically correct for us here in the United States, including something on this slide. So, and also there's a few words that are spelled differently in other parts of the world. So I don't want you to think that they are typos. It took a long time. When the system first came out, there were no codes for different types of hearing loss in different ears. So, which is sort of surprising when it's been used in other countries up until now. So if it says restricted hearing, that means there's hearing loss in both ears. So that means you're going to have one code for the right ear, and then you're going to have a different code for a different type of hearing loss for the second ear. So let's just take an example. If you had conductive hearing loss in the right ear and you had a different loss in the left, you'd use H90.A11 for the right ear. And then let's say they had, and those are the unrestricted ones. So this is the one you would want if they had a sensory neural hearing loss in their left ear, which would be H90.822. And again, you know which ear it is because of the last digit that you see. Okay, and again, here's just the ones for the mixed hearing loss. I'm just gonna go through those so that we can get through. Here's how it would look if you had an ototoxic hearing loss and they were given cisplatin for some type of a neoplasm in the brain. So the corresponding number that you see going down, A, B, and C, corresponds with those codes. So the A would be the H code, the B would be the T code, and the C would be the C code. So not anything you probably even have to worry about, because again, this is often done within an electronic healthcare system. But if you are generating your own claims, that's what they would look like. So again, I'm just going to go through some of these. The tinnitus codes I will highlight. So if you have tinnitus in your right ear, there's a code for that, left bilateral, and sometimes the patient can't locate it. They just know it's in their head somewhere. So H93.19 would be very appropriate. If it's pulsatile tinnitus, you certainly want to make a referral for that. And those are the codes for pulsatile tinnitus. And again, I'm going to go through these very quickly. I mentioned to think about other codes that you could use for comorbidity. So if you have that patient who you have to keep instructing for dementia, that's the huge range of codes, and you cannot diagnose dementia. You'll have to call the physician that treats that patient in order to get that. These are the codes for some kind of deformation or malformation. So the atresia, the microtia codes are in the Q section. So the R section is somebody comes in and they're complaining of dizziness, you're probably going to need R42. If a patient's referred by a pediatrician, for example, for delayed speech and language, you'll probably need R62.0 plus anything else that applies. So the T codes I've already kind of mentioned, but these would be the things that are given to a patient, but have, to help them with whatever issue they have, but then it causes hearing loss as a side effect. So those are what all the T codes are, whether it's for salicylates or aminoglycosides, anti-inflammatory drugs, diuretics. And now these are the solvents that can also cause ototoxic hearing loss. And you'll see here how it's interesting how it's given. Sometimes it's accidental, sometimes it's intentional. It's self-harm by an assault, or you just don't know. So these are all the ones that audiologists would use. So they're all here for you. And again, just as a reference, here's carbon monoxide. It can cause not only death, but if the patient survives, ototoxic hearing loss. So these are how the third code. So if you did the ototoxicity code, it would be for the hearing loss. The second code would be for whatever the drug was. And now these are the ones that could be the third drug if you so choose to use that. That part's not required, but if you're using an ototoxic hearing loss code, you also have to use one of the T codes. So this list is very lengthy. So again, I'm just going to go through it. Oftentimes you're going to see somebody who has complaints like tinnitus. You do all the testing and you don't find any abnormal findings. There's no code for normal, so you have to use Z01.10. It may get denied, but you don't have any choice. And here's some of the other Z codes. These would be used not necessarily as a primary code, doesn't go in that first A position, but if this is all there is, then you have to use it. Because remember, you don't bill for getting paid, you bill for what you did. So again, here's just a few others and some references. These are what the code books look like, but the best part I want to show you is that there's an app for that. So you can go to the App Store, and the one I use is the red one. So it's in my phone. I use it a couple of times a day, and then I don't have to drag around a code book that's about 3 inches thick. I'm going to go through the hearing loss codes very quickly because I only have, about 5 minutes or 2 minutes, and I wanted to have some time for questions as well if there are any. And I know I'm going very quickly. So there are the HCPCS codes, or the hearing aid related codes, and also the CI and osteo integrated codes live here in this section. They deal with what CPT did not. So there are some procedure codes, not many, but I want to highlight the 3 you see there. B5010 is assessment for a hearing aid. So you had 92590 and 591 on the CPT side for assessment for a hearing aid evaluation. Again, you're going to want to look at what your payer pays. Conformity evaluation would be really or some kind of validation for what that hearing aid's doing for that patient. And then finally, this is sort of a temporary code, but it's been around for a long time. You're doing hearing testing as part of the hearing aid evaluation. SO618 may be an option. So again, here's the claim form. This is where they go, where you see the blue ovals. And these are the codes. B5014, repair modification of a hearing aid, is something, modification's not specified if it's acoustic or physical. So those are some things to think about. This is very important if you're in a practice that is itemizing. So you have the device codes, some of which will seem very odd to you because there's not very many body aids around anymore. These are the newer codes for the cross and for the bicrosses. Not my favorite, I'll tell you. Dispensing fees, these are things you want to add in so that you can get paid for your services. If you don't do that, it's lost and you may be leaving money on the table. So you always want to do that. These are the most common codes. These are the digital codes for monaural, the digital codes for binaural, probably the ones you know the most. There are assistive listening device codes, and they're all here for you. There are ear mold codes, there are FM codes. So again, I'm not going to go into detail, but I will go back just to highlight, if anybody's in a practice doing lyric, hearing aid not otherwise classified because it's a prescription type of device. It's not one that's used for years and years, it's replaced. So B5298 is a great code for a lyric practice. B5299 is like 92700. It's for things that aren't covered that have no other code. A tinnitus device would fit into this, tinnitus services would fit into this, as well as 92700. And these are the cochlear implant codes as well as the osteo integrated codes. Again, they're here for you for reference. And then we're almost done, got another maybe 30 seconds. So there are some payers that don't understand what bilateral or binaural is. So they want to make you bill for everything you do with RT, which is the right side of the body, which in our case would be the right ear, or the LT, it would be the left ear. So I mentioned to you that I wanted to also go over the 1500 form. It's a standardized form. If you're billing electronically, you don't even see it. It's all within your system. But again, that's what it looks like. That's where the CPT codes go. And it is overseen by NUCC, and they have some great information on the website. And then they also have some interactive websites where you can look and see what goes in where. And here I have it for you as to what goes in which box, what's the place of service, because it's usually 11 for an office, and then these are just other boxes of what goes in. But these are the interactive sites. You can just click on that. It'll have a claim form there for you. You just hover your mouse over the box, and then it tells you what goes in there. So again, I want to thank you for having me tonight. I know some of this may not be things you're familiar with, and I know I went very quickly, but I wanted you to have a good background of all three coding systems. And Andrew, if there's any time and any questions, I'm happy to take them. And thank you guys so much for coming tonight. And I hope your AUD journey goes really well and smoothly. And I know some of you are in challenging times right now with the pandemic.
Absolutely, yeah. We have a few minutes for some questions. We'll start with this one. Can you explain why we should code for each and every test that we know is not going to be covered?
That's a great question, because somebody hopefully is going to pay, whether it's the patient, whether it's the payer. Plus, it's just what you need to do. I mean, that's a great question. So you want to code and bill for every single thing you did, whether you just use that internally. But again, you do a test and somebody needs to be billed for it. You don't give away your services for free. And Dr. Cavett will talk to you about that next week as to why that's even more critical if you're providing services to Medicare. So I'm going to say somebody's going to have to pay for it. And I know that's hard for some of us when we first start out, but you got to keep your doors open. And if you're providing a service, somebody should pay for it. You don't go to get your hair cut or have your car worked on without somebody, going over the bill and saying, this is what it's going to cost you, and this is what we need to do in order to get you there. So it's sort of the same thing in my mind. It's a great question. Do you have any more, Andrew?
Yes, ma'am. Looks like we have time for a couple more. Do
Okay,
you
great.
anticipate any other imminent changes to coding? I believe you mentioned some changes that you anticipated coming in November. Do you anticipate any other changes other than those?
If there's going to be any changes to the ICD-10s, those begin and are effective on October 1st. So we won't know, and I have no idea if there's going to be any changes with that. As far as the HCPCS code, I don't expect any changes for 2021 with those at this point in time. But again, as we mentioned, it will be when they're published, when the codes are the CPT codes are published in November, that's when we'll know what each BEM code, for example, is. There will be other codes. So we're going to be a little heavy on the CPT side. Those are effective on January 1st, and in this case, it'll be January 1st of 2021, but they're not published until November. And until then, you won't see what those codes are. They are published in the Medicare. Every year, Medicare comes out with a final rule that's supposed to be on or around November 1st, and that's usually when we first see them. And then the AMA publishes them in the code book as well.
Great. Looks like we have another question that just came in.
Mm-hmm.
If you think a pediatric patient has a syndrome that has not been diagnosed yet, has a genetic appointment set up, should I code for that syndrome?
I would not, unless it's in your documentation, because you can't diagnose that syndrome. As an audiologist, you might make some notes that don't say that, but you can't diagnose that. And the other issue is that goes to an insurance company, and now it's part of that record. So I would really try and dissuade you from doing that. You can only code for the reason in your findings. You could also have a conversation with that physician and explain your concerns to that physician, but I would not put it in your report until you know for sure. So if they come in with paperwork from their physician saying, they've been diagnosed with that, then you could. But for you to make that diagnosis, that is a dangerous path.
Great. And it looks like we have one last question.
Sure.
Do you have any recommendations for resources related to billing and coding? And I know you referenced the app that you used.
I missed the last part of your sentence, Andrew, that I referenced the what?
The app that you referenced in your presentation. Do you have any additional recommendations for resources?
Sure. Well, the CPT code book is probably your best bet, but it just has a listing of those. You could ask your professional organizations that you're a member of, that they can offer a little bit of help within the confines of what the AMA allows on the CPT codes. The HCPCS codes and the ICD codes are on the internet. They are in the public domain. So you can find those anywhere. And that's the easy part. It's the CMS part, the CPT part with the AMA. But I know ADA has some great resources, thanks to Dr. Cavett on the website. So I would suggest maybe if you can, taking a look at that. And for those that are Audigy members, that's what I do. So we would be a resource for you on that end.
Great. And thank you, Dr. Abel, and thank you to Kayla. Looks like we are out of time for today's session. If anybody has any additional questions, please send them to info@audiologist.org, and we will forward those on to Dr. Abel. If you have friends or colleagues that were unable to attend the webinar today, please let them know that this session has been recorded, and we will send out a link to attendees after the recording is posted. For more information about future SATA practice management webinars and to register, please visit www.audiologist.org/students. Thank you to everyone and have a great evening.